Hello, my name is Vikki. I'm a transfusion practitioner at University Hospitals Dorset on the Poole site. I've been working with the South West Regional Transfusion Committee in a small team, and we've been looking at putting an education day together to support empowerment of lab staff to challenge requests from medical staff. So I've got with me today Dr. Lee Grimes, and we're going to have a bit of a chat about how important it is to challenge requests that may appear inappropriate or unjustified, and how that conversation should go.
Inviting me, Vikki. I'll just briefly say who I am. So I'm Lee Grimes. I'm one of the haematology registrars. I work at Salisbury Hospital, but around the Wessex Deanery for the past few years. So thank you for having me today.
Thank you. So question number one would be, why is it important that lab staff raise queries for blood component requests with clinical staff?
I think it's vitally important for many reasons. I think the first thing I would like to say is that lab staff, when you're speaking to doctors, the doctor will have a wide variety of experience when it comes to transfusion. So you may well be speaking to a transfusional consultant in haematology working at the NHSBT, in which case you can be pretty certain that the request is going to be a legitimate one, and that's fine. But of course, you have to remember the request might be being made by a brand new Foundation Year 1 doctor, fresh out of medical school, who feels uncomfortable, who doesn't really have much understanding or education of transfusion, and they feel like they need to make the request because they're a real doctor now, and so they do. But of course, as you know, when the request comes through, the request might not make sense, and it is important for the lab staff to understand that the doctor will be coming at it from a variety of different experience and understanding, and if it doesn't make sense, it's important for patient safety and lab safety and doctor safety that the request is challenged or considered or discussed, however you want to put it.
I think discussion is a key word, because it's not that we're challenging and saying no. It's just that perhaps we're asking for a bit more information about the requester, a bit more information about the patient, and more or further justification for the request. Yeah,
absolutely. It shouldn't be, I suppose the word challenge has got some kind of connotations of confrontation. And I'm sure that, especially those that are more experienced, sometimes these calls can degenerate into confrontational calls, and that's got to be avoided at all costs, really, because that's not good for anyone. Nobody comes to work hoping to have a confrontational call, but the call, if it doesn't make sense, I do believe that we do need to have a system in place, and for biomedical scientists to feel empowered to just question and have a chat about the situation in the hopes that a sensible clinical decision can be made at the end of it.
Absolutely. And it is important to remember, as you say, that the person making the request, although from a lab staff perspective, we see doctors as all the same, you're all doctors, but as you say, there is a variety of experience and a variety of knowledge there, and it could be that the lab staff actually at that point in time have more information or more knowledge on that particular topic about the request.
I would say that in the vast majority of cases, the lab staff will have more knowledge. They'll be more up to date with the guidelines. They will have a better understanding of the transfusional codes and why we have them and the evidence base behind them. In the vast majority of cases, most doctors, unfortunately, during medical school and during their early training, unless they get direct haematology experience, won't have much more than a handful of hours, if that, of actual education in transfusion. So a biomedical scientist that's fully qualified and working in a transfusion lab most of the time will have more knowledge than the doctor.
Okay, so that's something that we need to remember, and something to give us confidence when we ask those questions. I bet as a Heme Reg you get frequent questions where lab staff are asking you to support challenges that they've perhaps made for blood component requests. Does that happen a lot?
Sometimes daily, depending on the hospital. Certainly in the bigger hospitals, we get quite rightly phone calls about transfusional queries. Smaller hospitals, at least once a week, I would say. And I think they occur usually when there's been a request made that's outside of a local policy or a guideline or a transfusional code. And oftentimes I take the call and we do a bit of digging and we understand the case pertaining to the patient, and we still approve it, even though it's outside of a policy. But a lot of times we say, no, that's not right. You're going to cause some harm if you do this in one way or another. It's not enough. It's too much. It's the wrong product. Why are you giving that? This isn't indicated. You're going to potentially cause a complication. All these things ultimately can happen, and hopefully we avoid them by having these conversations. But if we don't have the conversations, then we don't avoid them, do we?
No, and that is the important thing about this. This is a concise discussion, and each patient is individual, aren't they? So whilst we have guidelines and we have policies, it isn't a one size fits all. So it is about making sure that we have that information, and if needs be, pass that information on to you so that you can have that clinical discussion to make sure what's appropriate for that individual at that time.
Yeah, absolutely.
What do you see is the benefits to patient care with these kind of discussions? I think we've probably already touched on this a little bit, but what are the pros to discussions?
I think if I was a biomedical scientist, I would see myself as a fundamental gatekeeper to sensible decision making. There are many gatekeepers, there are many gates, but the biomedical scientist is a very key part of that process. And if it is assumed that the doctor is always right, then mistakes will be made. And I think that's the main message I want to send. There are many errors that biomedical scientists will pick up and down the country that are often near misses, catastrophic events, never events. Hopefully not too many of them, but there's different severity of potential mistake, and biomedical scientists catch and avoid a lot of them.
So there's all sorts of things, isn't there, that we can be a part of. For instance, as you mentioned earlier, avoiding over-transfusion, avoiding under-transfusion, ensuring that the component is targeting the request and we have the right type of component that we're issuing. So there's lots of pros, obviously, to challenging requests that seem to be unsupported or unjustified.
Absolutely.
My last question.
There's a huge educational component to that as well, isn't there? Every time that you have a conversation, whether it's biomedical scientist to doctor or haematology to doctor or whatever, there is an opportunity for actually saying, this is why we do what we do. This is the guideline that supports that. This is the evidence that supports that. And, if you have the opportunity, and then every conversation is an opportunity for education, right? It's an opportunity for
Absolutely
better at our jobs. And if you take an F1 or somebody who's just getting something flat out wrong, and you have the opportunity to kind of educate them and make them understand their role better, that's a mistake that's not going to happen again when they move to the next job, the next patient. Absolutely.
Every day is a school day, as far as I'm concerned, no matter who you are or what level you're at, because each patient is an individual and you come across different and new scenarios all the time, which build your catalogue of experience. So my last question, maybe a bit tricky, but how does a constructive conversation sound like? So how should lab staff approach these conversations with doctors? So
I think whenever you've got two health professionals speaking about a case, I think it's really helpful to have well, first of all, before I go into what I'm about to say, I think it's important that we recognise that we're all humans at the end of the day, and it's just a conversation between two human beings. And so I really like it when I pick up the phone and I say, "Hi, it's Lee, Haematology," and the person back to me says, "Hi, it's Simon from Transfusion." You are not, "Hi, it's Transfusion here." You're Simon from Transfusion. You're a human being, aren't you? Yes. So I think if we speak to each other as human beings and with respect, I think that you're on to a good start from the beginning, and it becomes instantly less confrontational because you're about to actually challenge somebody's decision, aren't you?
Yes.
When you're about to challenge someone's decision, I think it's important that you make sure that you're on the same page before you start challenging one another. So it would be helpful to use a tool, and doctors and nurses and other health professionals, I'm sure, will have come across the SBAR tool, which is situation, background, assessment, and recommendation. So if you structure it with them words at the beginning of each sentence, so it's, hi, it's Simon from Transfusion. The situation is I've had a request here for X product. The background is that the patient is bleeding. So it's a request for 6 units of blood, and the background of the patient is they're a 66-year-old who's bleeding. My assessment is that this might be a good opportunity to use the massive hemorrhage protocol, and I'm calling to see what your recommendation might be. That's
excellent.
25-second succinct problem that then you can go into the nitty-gritty of.
Absolutely, and it's clear and it's concise. It's, as you say, non-confrontational. You're not starting with a "I'm not doing this" or "I don't agree with this." It's constructive. It's offering solutions as well, not just saying this isn't right or this doesn't fit. You're saying, actually, from the information I have, perhaps this is better. This is what we would recommend in this situation, but also then being open to the feedback back. You know, they may then be provided with further information that it might be quite a fluid conversation.
Absolutely, absolutely, because it's important. You know, it's all about conveying ideas back and forth, isn't it? And you know, if the clinical description is bleeding, well, you know, what does that mean? And then with a conversation that goes back and forth, you'll have an understanding of what each of you are trying to say. Bleeding from, you know, they've scratched themselves and they're bleeding, or actually they're shocked, they're exsanguinating, this is a life-threatening situation. And once you're both on the same page and you can understand the clinical situation that's happening, actually the vast majority of the time you come to broadly the same opinion of the case, and that informs broadly the same plan of the case. Yes,
absolutely. So it's using concise language, being constructive, offering solutions, being open to feedback and discussion both ways, and then coming to an agreed outcome.
Absolutely, absolutely. And the vast majority of the times when you're on the same page, conflict doesn't even come into it.
No.
You just end up supporting one another, and you know, for certain, I get calls diverted to me all the time from biomedical scientists, and sometimes the biomedical scientists speak to me, or sometimes the doctor speaks to me. But actually, you know, the original doctor, the requesting the product, and the lab staff have actually highlighted a problem that neither of them in the first instance thought about, but working together, they've come up with something else that would benefit the patient, and then you know, that sometimes comes over to myself.
Okay. So ultimately, what we're saying here is better care, isn't it? It's better outcome for the patient, and that's what we're all trying to achieve, isn't it? The lab staff, medical staff, nursing staff, you know, we're all ultimately caring for our patients, aren't we? We all want the best for our patient. That patient could be one of our family members, and we want the best for them. So ultimately, that's what we are trying to do. We are not trying to argue or prevent necessary requests.
Yeah.
So
we're all humans trying to have a good day, and I think the main thing is to try and treat each other that way.
With a bit of respect and a bit of kindness. Okay, well, thank you very much for your time today. I'm sure this is going to be really helpful and useful in providing the confidence and a bit of know-how in having that discussion with clinical staff if requests don't appear to fit into the pigeonholes that guidelines create.